Hello guys, am I audible and visible? So today we will be discussing about few things for postgraduates. This will be for postgraduates, especially for exam going postgraduates. Even if you are in your second year or first year, if you want to learn few new things, you can. You're more than welcome, and we'll learn together. Fine. So to start with few things, these are for undergrads. If you are an undergrad or if you have a friend junior who are interested, they can enroll to Unacademy. They can use any code whatever they have. If they want a discount, they can use PathoCubs as well. Okay, and these are features of special classes which will be free of cost, which will be hosted on Unacademy app. And we've been doing the same thing for postgraduates as well. If you're new to the platform and if you're a pathology postgraduate, every Friday there'll be a class for first years. That's what I started recently. The last class was last Friday, which we discussed about the Coulter counter. Next coming Friday, we'll be discussing about peripheral smears, the basics of peripheral smears, and maybe a very few easy cases, right? So every Friday there'll be 1 hour session for first years. So I'll be covering all the basics, whatever I feel is required for a first year postgraduates. And there'll be classes for the second and third year postgraduates, or if you're a consultant as well, on Wednesdays and Saturdays. In this Wednesday and Saturday session, we have completed cervix, we have completed endometrium, we have completed bone marrows and lymph nodes, and we are en route to soft tissues. So if you are a final year graduate or a second year graduate who wants to read pathology, we'll be going in the form of cases, how to diagnose them, how to approach them, the differential diagnose, everything, fine. So all of them will be in the Unacademy app. You can download the app below in the description of this video, or you can just try Unacademy, it will come, and go to NEET PG section. In that, under my profile, you'll have all these classes free, fine. Okay, so let's start with today's. As I said that we'll be starting with a single case. Once we are done with the case, we'll go to the gross things, right? Because today's agenda is to learn a few things about crossing, and I hope you guys will be answering whatever I asked for. I hope you're live as well, fine. So we'll start with a simple one. This was the case which came yesterday. The slides were ready yesterday. I was a bit anxious to see them, so had went there and took a few images as well. We have not worked up the case completely, but I have a provisional diagnosis. I've asked for a few IHCs. I will update the IHCs in the due course. Fine. So this is a person. It's a 50-year-old person. It's kind of a retroperitoneal bar renal mass. The reason why I'm saying retroperitoneal bar renal mass is was not exactly sure where the lesion is arising from. Fine. It's either retroperitoneum or renal, because since the mass is very huge, the origin of the mass was not clear. The renal tissue was compressed, so either coming from the retroperitoneum or compressing, fine. So comment on it like we did for the last class. I'll be going with 10 seconds pointer for each of them. Comment whatever comes to your mind, then I'll discuss them and I'll tell you what IHCs I have put forward, and let's see what happens, fine. Every 10 seconds I'll change one image, so just look at them like you guys did yesterday. Try to comment on that. Second image. Third image. Fourth image. SN, you are fine. Sarcoma is a good diagnosis. This, I think you must be an undergraduate. It's fine. This is especially for postgraduates, and let's see if anyone can come with a better diagnosis than sarcoma. Sarcoma is obviously correct. Next image. Okay, this is the last, right? So I'll just go from the top again. These are the few images. Most of them are in the higher power. I don't have a scanner view. There are no kidney element attached to the mass. It's just a mass with all these fibers, elongated cells and everything. Anyone wants to attempt the diagnosis? As I said, it's a fresh case. Have not completely worked out. We have had a few provisional diagnoses and we went ahead with the marker. I'll definitely update you on the marker profile pretty soon, maybe a couple of days later. Fine. Anyone wants to go with the diagnosis? It's a pretty easy one. Just comment whatever comes to your mind. Even if it's sarcoma, I'm more than happy with that. Okay, our provisional diagnosis for this patient was synovial sarcoma, right? So we thought of a monophasic synovial sarcoma. We are not exactly sure about it because since it's a retroperitoneal mass, there can be many possibilities of a spindle cell lesion. One of the possibilities is synovial sarcoma. We went ahead with that. The reason for going with the synovial sarcoma is one is the cellularity. See, synovial sarcomas, ST is for soft tissue sarcoma. The reason for going for synovial sarcoma is the cellularity is very abundant. Whenever you see any case of synovial sarcoma, the amount of cytoplasm will be very less. They'll be very jam-packed cells, right? And they are short fascicles. Though in this image, if I can call, this kind of looks like an herringbone appearance, right? This appearance is, though not exactly, but yes, it does resemble a little bit about herringbone. So fibrosarcoma is definitely a differential diagnosis here. So first DD is a synovial sarcoma. We have asked for markers. If it doesn't turn out to be synovial sarcoma, we'll go to fibrosarcoma. One more classical finding is, this is a very characteristic finding, especially in case of a monophasic synovial sarcoma. You can see these vessels which are looking dilated, right? They are dilated hemangioperitomatous like vessels, right? So these dilated vascular network is very common in case of a monophasic synovial sarcoma. Almost in every image, you have the dilated capillary networks, the hemangioperitomatous like areas. That's a very characteristic finding for a monophasic synovial sarcoma. Might not be seen in a fibrosarcoma. That's why we went ahead with that. Let's see if it turns out to be synovial sarcoma. It should be great. Fine. Okay. So if you're a postgraduate watching here, can any one of you tell me the markers for synovial sarcoma? What markers will you mark for synovial sarcoma? What markers do you want for synovial sarcoma? I'm sure you know at least a few common ones. Any marker which comes to your mind? Keratins are definitely useful for synovial sarcoma. Anything else? There are few. Of late, we rely more on one specific marker. If that marker is positive, the confidence interval increases a lot. Good evening, Manpreet. For synovial sarcoma, we are in the first case of synovial sarcoma. I just want markers, whatever comes to your mind. Have you read about a marker called as TLE? The TLE3 or TLE. TLE is a very good marker, right? TLE1. It's a very good marker. If it is positive, it's kind of more specific for synovial sarcoma. It helps me to rule out from many other sarcomas, the microscopic finding which are close differential diagnosis, right? So we have applied TLE3. Along with that, we have applied a few more markers as well. Hopefully, if TLE3 comes positive, we'll be signing out as in monophasic synovial sarcoma, right? So microscopy wise, there are two differential diagnoses for the above case. One is in fibrosarcoma as such. The other one, it could be a Leomar Sarcoma. And because those are the two things which can be spindled out and which can become common in the retroperitoneum, right? Again, the diagnosis, everything should be based on your location, the age and everywhere, right? So if you look at this, yes, Ramya, correct. So usually you'll have a herringbone pattern. Like in this case, I said monophasic synovial sarcoma can also have an herringbone pattern, but only focal. This is very important. I'll go up to the case because whenever you see herringbone pattern alone, I don't want you to jump for a synovial fibrosarcoma because that's what you must have read, right? So if you look at this, I said that this looks like a herringbone pattern. Yes, it is a herringbone pattern, but here it doesn't look like. 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 So focally, synovial sarcomas can have herringbone pattern appearance. So just with the herringbone appearance, do not go to call it a fibrosarcoma. Fine, I can have them focally. So if you have a doubt between synovial or a fibrosarcoma, definitely markers is going to help you. Collagen might help you, though the collagen was not much appreciable in this case. I'm going to ignore them. Calcification is not a classical finding. As I said that most of the cases of monophasic synovial sarcoma, I'll have this. We saw them. The dilated vascular network is one of the classical findings seen, especially in a monophasic synovial sarcoma. Biphasic tumors might not have it. See, because the simple reason being, when I'm having lots of fibrous tissue, right, sarcomatous tissue, what happens is it becomes very firm and hard. I'm having a tiny vessel. The sarcoma, any fibrous tissue or a mesenchymal tissue will have the tendency to pull. So it kind of makes them a little bit elongated, right? So I have a tiny vascular network here. Because of the gradual pull of the lesion, it becomes like a dilated vascular channel, looking like a stag-on appearance, right? Hemangioperitomatous pattern is very common in monophasic synovial sarcoma. might not be classically seen in your biphasic synovial sarcoma, but in a monophasic, it's definitely very, very commonly seen, right? Nuclear morphology also helps us. Fibrosarcomas will have a slender nuclei with an elongated cytoplasm. Cytoplasm will not be seen much in your synovial sarcoma. Like I said, that this is a game changer. So we apply for TLE3. We hope it is positive. If it is not positive, we have to go back to the starting to apply for other markers, right? So it's classical synovial sarcoma, monophasic, even my light microscopy. Hope TLE3 turns out positive. The second differential diagnosis, again based on the location, could be a Leomar sarcoma, because Leomar sarcoma can literally happen in any part of the body. It's from smooth muscle. Every part of my body has vasculature, and every vasculature can give rise to a Leomar sarcoma. Fine. So Leomar sarcoma will be very, very pleomorphic. We saw at least 4-5 images. There's not much of pleomorphism. That itself roots against a Leomar sarcoma. If I want, I might require SMA to diagnose them. We are not applied that, so we are relying on the same TLE1. If TLE1 is positive, diagnosis is going to be monophasic synovial sarcoma only. Fine. So that was the first case. Just a simple case because it was looked interesting and I want to share it. Fine. So today's class is about gross specimen and technique discussion. So I'm going to discuss gross images only. Fine. So I'll show you images. I'm not a fan of taking gross photographs unless and until it's going to be published. So all the images, whatever I'm going to use, are from standard websites or from articles. What we'll be discussing post the image or post discussion of your diagnosis or differential diagnosis and how to gross the tissue is more important than the image per se. Fine. Okay. So comment on your differential diagnosis. It's a 50-year-old. I'm sure you know that it's a hysterectomy specimen. So tell me your comments. I'll keep quiet for next 30 seconds. I want you to describe the image. If you're a postgraduate, description is very, very important for gross. Describe them and then tell your probable differential diagnosis. Okay, describe the image and give me possible or probable differential diagnosis. I know Manpreet and Ramya is online, so I would ask you guys first. So others who are there, please pitch in, and I want a differential diagnosis. Then we'll try to discuss few things about grossing, a normal cervix, normal uterus, benign, neoplastic, how to gross them, what all biopsies what all bits to take. Fine. No one wants to take a call. Simple image, right? Okay, I would start with Dr. Deshmukh. Carcinoma is a bit, I would say that's definitely a possible differential diagnosis. Hysterectomy specimen and endometrial cavity distorted, great. That's a good way to start with, right? So if you have description is what is all required in a grossing. When you go for an exam in grossing, they want you to look for description. Whenever you describe any structure or any sample, anything given to you, the first thing is, first I want you to name the surgery. Hysterectomy has different types. A simple hysterectomy or an hysterectomy with bilateral salpingo-oophorectomy or your Wertham's hysterectomy, though it's not being done very often these days, right? So that should be the first thing. Whenever you describe any gross specimen, so tell the type of specimen. That's the first and the most important. So I've got in this, I cannot say whether it's only hysterectomy or a bilateral salpingo-oophorectomy because only one section, right? So you have to say, okay, this is a hysterectomy sample or a hysterectomy with a bilateral salpingo-oophorectomy with attached both tubes and ovary. You can use any word, fine. So second is, on the cut surface, like Manpreet said, that the starting point would be an endometrial cavity. It's distended by a polypoidal lesion growing from the wall of the endometrium. That will be a better description here. If you want, you can add cervix later on. I would prefer that whatever part is not normal, start with that, then go with cervix. Always do not say cervix is normal, then go to endometrium. Endometrium is definitely abnormal here. So the first thing is here, endometrial cavity is dilated and is distorted better. I can definitely use the term, it's a polypoidal mass, right? It's definitely growing inside the endometrial cavity from the lining of the endometrium, right? By a polypoidal mass from the wall of endometrium. Hopefully from the endometrial lining only, fine. So once you tell it's a polypoidal mass, there are only two differential diagnoses here. What could be that? Can this polyp be an leiomyoma? Is that possible? It's definitely possible, right? This polyp could be a leiomyoma. This polyp could also be an endometrial polyp, or it could be an endometrial carcinoma, right? These are the three differential diagnoses I can have: your leiomyomatous polyp, or an endometrial polyp, or an endometrial carcinoma. So to call it benign or malignant in gross, if you are able to justify that, that will be great. Otherwise, leave it here. Most likely a polypoidal lesion of endometrium. I would want microscopy to give a differential diagnosis. That should be more than enough, right? So if it is a polyp, as I said, that there are three possibilities. It could be a normal endometrial adenomatous polyp, it could be a leiomyomatous polyp, or it could be a carcinoma. I wouldn't think of an endometrial stromal lesion, because if it is an endometrial stromal lesion, what should have happened is your myometrium should have become bigger. Myometrium is not thick here. So endometrial stromal lesions again has a very classical appearance of an bag and worms, very sarcomatous appearance. I don't have that here, fine. Okay. So to call it leiomyomatous polyp, one classical finding is the cut surface. Am I right in saying that whatever may be, the cut surface of a leiomyoma should be whorled and solid? That's how it will be, right? Be it an intramural leiomyoma or a submucosal leiomyoma or whatever location it is, the cut surface should be whorled and solid. Is this cut surface whorled and solid? It is not, right? I don't have a whorled and solid cut surface, so my possibility of this is bit rare. So I'll come back to your endometrial polyp and your endometrial carcinoma. So these are the only two differential diagnoses for me yet now, right? So if it's an endometrial polyp versus endometrial carcinoma, carcinomas of endometrium are very classical. So whatever subtype it may be, it will have areas of necrosis. In this image, are you seeing areas of necrosis? Is there areas of necrosis seen? There are not much of areas of necrosis, right? I don't see a necrotic mass. It's firm. It's firm. If it is necrotic, it will be friable. You can appreciate a necrotic mass. If you have a gross image, gross in your real exam, you can definitely feel them. Definitely you can say it's necrotic, right? So without necrosis on the gross, for me to comment something as carcinoma is bit out of the bounds, right? I will not think of as carcinoma here. I'll come to GD, ESS, why I wouldn't think of an ESS, right? So my first possibility here is endometrial polyp, right? So these all things should go into your thought process before writing what I want. So it's a polypoidal mass in the endometrium. On the cut surface, it's more or less normal, it's smooth, it has few classical cystically dilated spaces. These are very important. Polyps can have cystically dilated glands, it could be, right? It's more or less homogeneous with few interrupted polypoidal cystically dilated space. If it contains mucin in a real life, comment they are filled with mucin. There are not much of areas of necrosis. When you comment there is not much of areas of necrosis, you are committing that it is not a carcinoma, right? So when you say it is not a carcinoma, every part of your description should be towards benign. At the end, we can put definitely a disclaimer. I'll tell you how to put a disclaimer as well, right? So when I say it's more likely a benign lesion, I have to say that surrounding myometrium looks unremarkable. When I say surrounding myometrium looks unremarkable, I am commenting that there is no invasion grossly. The isthmus of the endometrium and the cervix also looks unremarkable. If you want, you can measure it. Personally, I wouldn't want someone to measure cervix unless and until it is abnormal. If it is abnormal, makes sense, but a normal cervix, I need not measure, fine? So this part, you have to measure. Measure this in 2-3 dimension, whatever possible in the gross, measure it and write it, fine? So my first possibility here will be an endometrial polyp. The disclaimer, what I said you want to put is, though I have a possibility of an endometrial polyp grossly, I would want to look at the stalk of the polyp or the junction of this endometrium and the myometrium to look for invasion microscopically to rule out an endometrial carcinoma. Because even a very benign looking polyp in gross can have invasion in microscopy. If it is invasion in microscopy, I am going to call it, everyone is going to call it endometrial carcinoma, right? So the wordings are very important when you word out in a gross in an exam. First, start with the type of specimen. In uterus, I need not tell the laterality. If it is a breast parenchyma, if the mastectomy, if the knots are there, and I want you to comment on, okay, left radical mastectomy or a right radical mastectomy. In kidney, yes, left and right is very important. Organs which are bilateral, I want you to comment, okay, this is a type of specimen, mostly left or right, if you can, right? If you're not confident in commenting on left or right, don't commit, because when you commit, they'll ask you the next question is, how did you identify it is left or right? So if you're confident on that, give it outside. Don't give loose ends to an examiner. It will be useful for them to ask you reverse question from that itself, fine? Then whatever part is abnormal, start with that part. I would prefer to start with that part rather than saying rest of everything is normal, fine? My possibilities everywhere is these only. Inflammation, neoplastic. Neoplastic means benign malignant. This is the same dictum for microscopy as well as gross. Here it looks neoplastic because I'm having a huge growth. It unlikely will be any infection here. PID or your endometritis will not have such a huge polypoidal lesion, fine? So this is how you have to start with. So once you comment that this is most likely an endometrial polyp, the next question, see, let's assume I'm the examiner, I'm going to ask you leading questions. I want you to say what you will do, fine? The first question obviously will come to you is, how will you gross a specimen? What all things is required? How many samples bits are required to gross the specimen? It could be a very massive endometrial hyperplasia also, by the way, fine. GD, why not ESS? ESS has a very specific appearance. You must have read them, it's like a bag in the worm appearance. It'll have like tiny, no, I'll show you image of ESS sometime. On the cut surface, you can see tiny protruding appearance. They'll be like a noodle kind of pressed out of it, fine. That's a very classical finding of an endometrial stromal nodule or stromal sarcomas, which is not present here, so I would not think of an ESS here, fine. Okay, coming back to my question. What all these bits you will take for an endometrial hyperplasia or an endometrial polyp for that matter? What all bits you will take? We'll assume it's an endometrial polyp and we'll see what all bits to take. I want you guys to comment. It's fine if you're wrong, it doesn't matter. I'll not ask you questions also. You just answer, comment whatever you know, that's fine. We learn by doing mistakes. No comments? Okay. The first thing, the polyp should be perfect. Polyp with myometrium is very important, like Deshmukh said, right? The first and the foremost thing, the entire polyp should be dissected. The entire polyp should be sliced at 0.5 to 1 centimeter thickness. This you have to tell to the examiner, but in real life, you know that it's difficult to dissect a polyp in 0.5 to 1 centimeter thickness. Whatever is the easiest available, do that. If you're going to become a consultant and if you're going to report the patient, I would want you to use a microtome blade. Microtome blade easily slices through a polyp and take a new microtome blade. The best one, I would say, after frozen section, they will discard the microtome blade. Take that microtome blade before they use it for the routine block cutting, because that can cause ragged edges. A new microtome blade, how much ever big it may be, let's assume this is your myometrium. Here, you have to slice it. At one point of the slice, definitely, like you guys said, that it will be in touch with the myometrium. Actually, if it's a three-dimensional structure, right? I'm not bothered about the thing which is protruding here. It's protruding here. I should ideally take specimen from that also, but still, I am more concerned about this part, fine? So when I take the part where it exactly meets my myometrium, I have to give it entirely. And the most important thing is here. This is very important. The stalk, like you guys said, the polyp is important with myometrium. This is important. If it is less than 2 centimeter, the entire polyp, please give bits completely. You have to exhaust the polyp. If it's less than 2 centimeter, you have to completely exhaust the polyp. If it is more than 2 centimeter, because sometimes polyp may be huge, this is useful for any polyp dissection, be it endometrial, be it colonic. More than 2 centimeter, whatever stalk is there, because if the stalk itself is 2 centimeter, I can have 2 bits from the stalk, right? What do you mean by say is, I can have this connected to the stalk, maybe the next cut section also is connected to the stalk. I have to take both. Don't ignore that. For a polyp which is huge, more than 2 centimeter, my main concern is not the overhanging parts, the parts which is attached to the underlying myometrium or underlying mucosa in your colon, fine? From that parts, I have to completely gross it. Every bit of the polyp which is connection with the stalk should be sampled. Don't ignore them. When you come to a commercial setup, you might be asked questions of why so many slides. You should not budge for that. This is the bare minimal requirement what I'm going to do. I'm not doing as per the CAP protocol. CAP says a totally different approach. This is the bare minimum required in order to not to miss a diagnosis, because invasions can be very, very subtle and tiny. I don't want you to miss that. Fine, that's first. So polyp should be sampled first. The next thing, I also need to give a bit from a normal myometrium. If it has something tiny leiomyomas, give from that. I need to give from cervix. I need to give from the isthmic part. Right? These are just to complete it, because I cannot ignore them since it's an hysterectomy done. We have to give a comment on the cervix, endometrial part, and the polypal part as well. That's how you cross an endometrial polyp. Right? Well, let's do something. We'll take the entire female genital tract and I'll try to see how to cross each one of them. Fine. We'll start with cervix. If you remember cervix, we did read this when we discussed FGT as well. Cervix can have conization. Cervix can have the loop lead procedures. You can have a trachelectomy. Though the surgeries of trachelectomy are becoming very rare these days, they remove the entire cervix. They remove the entire uterus. They don't remove the cervix alone. But theoretically speaking, you need to know how to conize the cervix, right? And also you need to know how to dissect or gross and trachelectomy specimen. Fine. So let's start with conization. Fine. So can anyone comment on how to conize the cervix? Because conization might be required. That's important for you. Conization might come in an exam, might come in a real life as well. How do you conize the cervix? That's one of the basic requirements which you have to know. Okay, first and the foremost thing for conization is look for the mark. Conized cervix should be marked. If it is not marked, I am going to ask, put that in writing in the form. I will ask the gynecologist to help us. Unfortunately, if it is not marked fresh, you will not know which is the correct one. Fine, yeah, clockwise is perfect. So I need to know which is the marked area. Generally, the marked area is 12 o'clock. It's considered 12 o'clock because unless and until it is marked, I will not be able to say which part of the cone has the lesion, whether it is anterior or your posterior or right lateral or left lateral. Marking is very, very important. If it is not marked, just say it is the conized cervix is not marked and I can't do anything. I will definitely give all the 4 o'clock portion, everything I'll do give it, but I will not be able to comment if at all there is an invasion, which part or the which part at CN or something. I will not be able to give. Fine. So once you get a cone, okay, let's assume this is a cone. You have to ink. Most of the time we miss inking. I don't want this ectocervical face to be inked. I don't want the endocervical face also to be inked. What is more important for here is, see, conization can be therapeutic as well as conization can be diagnostic for a much radical surgery in the future, right? So this part of the cone, because if this is a cone taken from a much larger cervix, this part of the cone and this part of the cone is attached with your body. So this margin and this margin is what is more important for me than my topmost and the bottommost. Ectocervical margin is not important for me. Endocervical margin it might be important because that might extend up as well. Fine. But what is more important is the lateral surface, because since I'm looking for a cervical carcinoma, I don't expect it to grow here. I do expect it to grow on the sides. Fine. So this deep ectocervical margin and your endocervical margin has to be inked at any cost. If you want, you can ink the endocervical canal as well. This is not much required. If you want, you can ink it and say that, okay, the lesion is so and so diameter, centimeter away from the free ectocervical face. Not required generally, but these two inking are must. And like Ramya said, that I'm going to gross them in a clockwise fashion. Yeah, okay, perfect. Parallel cuts or a clockwise fashion. You cut them from 12 o'clock, just open them. Before that, very, very important, fix the cervix properly. And the way to fix a cervical cone is, once generally you receive the specimen the day before, right? You mark, you ink, let it dry. After drying, put a horizontal cut surface with a very, very sharp blade from the outer surface going directly into the canal. It should be a single cut. Just spread it, pin it and put it in the formalin tissue if possible. That's the best way to do it. If not, like usual, you can just cut and keep it. The formalin will definitely seep inside and it would have fixed the tissue, right? Then 4 quadrants, give everything. The most important thing is, when you fix with formalin, it will retract. So keep in mind, the purpose of pin is that, because when you pin a tissue, see, because it's a cone and I cut and keep it like this, I'm going to pin here. When I'll pin the mucosa to the stroma to the board, which means even if it shrinks, the mucosa doesn't separate from the stroma. If I don't pin, if I just only cut, mucosa shrinks a lot. So sometimes, unfortunately, and the cut portion, you won't have mucosa at all, and everything would have retracted and gone to the next overclock portion, right? So that's the reason you have to pin it. If you pin it, that will be the ideal way to do it, and the pin should be perfect. The purpose of the pin is not to expose them to formalin, is to make sure the mucosa doesn't retract and go away and it doesn't separate from the stroma. So pinning is important. Please try to do that whenever you do it. And like usually, cut it, label it 12, 3, 6 and 9, and then look at the microscopy. We have read about the microscopy previously. If you have missed those sessions, it will be there in the app under my name in the Unacademy. You can just go and have a look at it again. Okay. If it is a radical trachelectomy, see, radical trachelectomy, as I said, that it has become a bit rare these days. Radical trachelectomy means it includes your cervix, ectoendocervical canal, and along with that your parametriums. That's important, and little bit of vaginal cuff margins also will come. So this is how a radical trachelectomy specimen looks: the cervix and the parametrium. Okay, so as usual, we have to ink the margins. Here I need endocervical. Here I would need the peripheral cervix, the parametrium, right? I would require the vaginal cuff end also. I would require this end. This margin is important. I require this end. I require this margins as well, because these are the structures which are attached to the patient's, which is there still in the patient's body, right? So if we have something problematic here, I need to extend the surgery. Same holds true for all of the four. So the four margins which is very, very important for radical trachelectomies is the vaginal cuff margin, right-left parametrium, and the endocervical margin, right? And again, cut this. This is how I said you to gross. Even conization, I'll cut here, and you will put pins here. You will put pins here. It should come from the mucosal surface, obviously, and put it into the board so that this mucosa will not retract here. The purpose of pin is that, and then you can gross it like any other organ. You give adequate bits for radical trachelectomy. Try to take the pictures if possible. Fine. If you grossly are seeing a tumor, take from the tumor alone. It's not required to remove everything. If there's a previous conization done, like in this image it's given, look at the report. Why I want you to look at the report is, if a conization is done, you will know where the tumor is, if it's properly marked and everything. Then in that part alone, I'll take a little bit more bits. I will ignore the rest because already conization is done, so I need not worry about the rest of it. Only at 5 o'clock portion there's a tumor, and the 5 o'clock portion direction alone I'll take more bits to see whether it's extending or not. I need not worry about much of the rest. Fine. So if the previous report is there, try to correlate and go ahead with that. Okay, that's with cervix. I'll go to fallopian tubule. I'm sure you must have crossed fallopian tubes, right? Because tubectomy is one of the commonest thing which comes in your lab. What do you do for fallopian tube? We don't generally do anything, right? We take a tube, cut it to pieces, and we throw away, right? We just say that lumen present. It'll be 2 pieces. We'll just directly you will give it to your technician to embed and cut it, right? So for fallopian tube, the most important thing for us is CFIM protocol. Okay? CFIM protocol is important. Again, CFIM protocol can come in an exam for you, as may come as your question, or it can come when they're discussing about a grossing protocol for either for ovarian tumors or regarding a fallopian tube. What does CFIM stand for? What does CFIM stand for? It's sectioning, extensive examination of the fimbriated end, right? FIM for fimbriated, SEE for sectioning and extensive examination, right? CFIM protocol, yeah, perfect. CFIM protocol is very, very important for your analysis of your stick lesions, right? That's and complete grossing of cervix. CFIM protocol is very important when you are having an ovarian lesion, ovarian serous lesion. This is one of the ways to do it, right? So you must have seen an tubectomy tube with the fimbriated end. So what CFIM protocol says is, I have to cut the fimbria and sample the fimbria. At the same time, I have to transversely cut the rest of the tubule as well, right? So the first step in CFIM protocol is cut this and remove it. So that's how it should be. You cut and remove it. So it's fimbria. Fimbria will be very much fimbriated. It will not be a uniform organ, right? So fimbrial end should be longitudinally cut. I have to cut the entire fimbriated end longitudinally. An ideal way is to cut is sometimes fimbria can be very bulky, sometimes can be very thin. It is said that don't give more than 2 or 3 bits in a single cassette. If I have a very bulky fimbria, let's assume there are 5-6 bits coming, 2-3 maximum in a cassette. Don't give more than that, because if you give more than that, the orientation will be lost. The mucosa is what I'm interested in, that will not be easily seen, right? Maximum 2 to 3 bits per cassette. That's very important. That's also the protocol. It says that I should not give more than that. And next here, this is like your routine fallopian tube. You cut them, look at the lumen and embed the lumen facing up or down, right? So this is Sequential protocol. You have transverse cuts for this and the longitudinal cuts here, right? These are images from RC path, longitudinal cuts and transverse cuts, right? Once you cut here, this is how you have to do. Take it and remove it, and these are the transverse ones, and the transverse ones should be exactly like this. The orientation is very important. 2, maximum 3. Don't give beyond that in a single cassette. And this you can give as much as possible. If it holds 3, 4, it's fine, because here what I'm looking at is also the lumen, but I don't want the outer surface here, right? The lumen is in the center, so 3, 4 easily can fit into a cassette. But for a fimbriated end, 2, maximum 3 in a cassette, right? This is Sequential protocol. You should be able to comment on this. This becomes extremely important if your center or if the pathologist who is coming here is a bit inclined towards oncology. Fine. Okay, next. Look at uterus. How do we gross uterine lesions? We have multiple uterine lesions. Like we do have, like it's seen here, I can have a myomectomy specimen. Uterus benign is what endometrial polyp. I'm not going to repeat that. And uterus malignant is for carcinomas, right? So what do you do for myomectomies? Have you examined myomectomy specimen? Definitely you must have examined myomectomy specimens, right? So if you've seen a myomectomy specimen, the first thing is, what is important for me is the weight. So we have multiple things. If you examine myomectomy specimen, have you received them in bits and pieces or a single large myoma? Both of them are possible, right? Of late, it's more of bits and pieces because it's been done under laparoscopic procedure. I cannot take a 10 centimeter myoma via laparoscopy, so it comes in like coarse. It's called as a morcellated specimen, right? The words might be important. You must have definitely used this word, a morcellated specimen, right? It'll be like long, coarse like your prostate. Same like a transurethral resection of prostate, I'll have tiny pieces, right? So the first important thing is, if you remember prostate, when I got prostate TURP chips, what do you do first? Prostate TURP chips, while grossing, we definitely do one. What is that? What do we do? We weigh. Perfect. Here also, if the myomectomy is a morcellated bits and pieces, first I need to weigh the specimen. Okay. Generally, myomectomy is done for benign lesions only. If there is even a tiny little bit worry of your malignancy, they won't do a myomectomy. They'll go for a radical hysterectomy, right? So the chance of carcinoma in a myomectomy is very rare. At least in a bits and pieces, it's a bit rare. So what I do is, I have to weigh it. If anything is less than 5 grams, embed all. Just embed all if anything is less than 5 grams. If something is more than 5 grams, similar thing we had for prostate as well, I need you to gross for 5 grams. That's enough. A random bits of 5 grams is more than enough. Again, maximum 2 cassettes. Maximum 2 5-gram tissue. You take a little bit of it and keep them in 5 to 6 cassettes. You need not give more than 5 to 6 cassettes, even if the myoma is, let's say, 20-30 grams. Even if it's in kgs, I don't want to give more than 5 to 6 cassettes. You can select and give. See, this was a protocol says, if you are not examined 5 to 6 cassettes for anything more than 5 grams, you might have missed few lesions. Then it is difficult for us to go and substantiate your finding, right? So if anything more than 5 grams, you should have at least a minimum of 5 to 6 cassettes, which means 5 to 6 slides for the myomectomy specimen. That should be more than enough, right? I need not sample everything. Less than 5 grams, you have to sample everything. If it is less than 5 grams, definitely it will fit into 2-3 cassettes, doesn't matter, fine. If it is a myoma the entire myoma. An intact myomectomy, again, it is becoming rare these days, but still you can still have an intact myomectomy. Intact myoma also very serially cut. You gross them like a routine myoma, and an intact myomectomy, it's based on centimeter here. I'm not going to based on weight. Less than 10 centimeter and more than 10 centimeter. And the most important thing is you have to also document that how many Leomar bits are there. If it is more than one or less than one, even if it's more than one, I'm going to look for the maximum biggest one only. Fine. If it is less than 5 centimeter, 10 centimeter, I have to take at least 5 representative specimens, 5 bits minimum. Again, whatever I'm talking are for myomas with perfectly homogeneous architecture. If you have a slightly little bit of query necrosis also, take more bits. Fine. If it is perfectly homogeneous, white, tan, circumscribed, whorled, everything is there, not even hyaline degeneration, no degeneration at all, 5 bits should be more than enough for anything less than 10 centimeter. If it's more than 10 centimeter, I want you to take at least, it's based on how many nodules it is, because when it's very big, it'll become nodular, right? It'll become nodular like this. Fine. For anything more than 10 centimeter, I want you to submit at least 3 sections from the largest nodule and 3 sections from the smaller nodules, because more than 10 centimeter will not be single nodule. Fine. 3 bits from a larger nodule and 3 bits from smaller nodule. The only difference here is I'm not increasing the number of cassettes here. The only difference here is I'm selecting where to take from, because it's very large specimen. I need to select where to take from. I'm having a myoma like this. Let's assume this. From this larger nodule, I take 3 bits and I take 3 bits from the smaller nodule. Fine. I have to just select, that's all. Number of bits is still enough. 5 bits to 6 bits is still enough if and only if it is homogeneous. If it is not homogeneous, if it's heterogeneous, I have to sample as much as possible from the heterogeneous area. Fine. Okay. Just a question for you. How will you pick up necrosis in gross of a myoma? Because you need to pick up necrosis in a gross of a myoma. If you're not able to pick up necrosis, you will not be able to properly sample, right? How will you pick up necrosis in a gross of a myoma? Or what all changes in gross is suspicious? I'm not just saying it's necrosis, just suspicious change. Anything which you feel grossly will be suspicious. Any area which has hemorrhage, please sample more. See, all these are pointers for saying something abnormal it is. Fine. I think normal, whatever you want to say, umbilicated areas, it's softened areas, right? Hemorrhage, any softening, it's very important. Exudates, what do you mean by exudates? Because exudates is a bit of a different term when we talk about a myoma, right? If it is discolored, it's important. It's mostly it will be slightly blackish to brownish discolor. If you feel it's not well circumscribed, it's infiltrating and it's been cutting off, right? When you see infiltration, and this infiltration is especially useful for an hysterectomy specimen rather than a myomectomy specimen. Fine. Okay. So all these warrants more sampling. And when you have any myoma, be it a myomectomy specimen or an hysterectomy specimen with all these changes, I should give 1 bit every centimeter, and more so in all these, right? I give 1 centimeter, 1 bit, because that's the approved dictum. If you have a myoma for 25 centimeter in the largest dimension, I need to give minimum of 25 bits. If the atypical nodule is only 10 bits, only tiny, I have a big normal nodule and a tiny atypical nodule, sample everything. Fine. 1 centimeter per bit from all the suspicious areas is must. And if you feel after looking at the microscopy, okay, there is something not good for me, anytime you can go and regross. Sometimes grossly it may be completely normal, microscopy it might look abnormal, that time I'm definitely going to go and regross it, right? So these are for your myomectomy specimens, right? And we know about the uterus benign lesions. Now we just a quick discussion about endometrial carcinoma specimens. What all these samples do you take for endometrial carcinoma? Let's assume it's an normal uterus with an salpingo-oophorectomy, and you're having an infiltrative lesion here, fine, and your isthmus. So what all samples do you want? It's a normal case of an endometrial carcinoma, or let's assume frankly invasive adenocarcinoma of endometrium. So what all samples do you want, and how do you cut it first? Because cutting is important. You can either slice parallelly along the canal after putting in a probe, or you can slice from the top. I will leave it to your comfort. You can slice either from the cervix or you can slice from the top. It's totally your comfort. There's no hard and fast rule how you have to slice. That's totally your comfort, fine. Again, you can slice across the tubules, that means like this, or you can slice the other way also, fine. Anything is acceptable until it's going to make you comfortable. There's no rule that you have to just cut open only in the transverse or the longitudinal direction. I need to cut open the uterine cavity properly, that's all, fine. Okay, you cut open the uterine cavity, you cut here transversely looking at the both your fallopian tube and your ovaries, fine. So what all specimens, what all bits do you give? What all bits are required? If you have given bits, I'm sure you must have given bits for this. I need 2 bits from cervix. Generally what we do is we, just for the sake of just for the sake of minimizing the sections, we put both the cervical anterior lip and the posterior lip in the same cassette. Try not to do that. Give it in 2 different cassettes. That's more important. Sometimes for staging it might be required. Mucosa might not come properly if you give both the thing in the same cassette, fine. And obviously after that what I want to do is take an entire slice, like Deshmukh said, that I want you to look from the deepest invasion, because you will cut serially. Once you cut serially, look at the flap which appears deeply invasive. That's the first step. 4 from tumor and 1 from adjacent endometrium might not be required. I want you to serially completely give it, right? So you cut it serially and look where it is invading maximum to myometrium. Take that slice entirely. And once you take the slice entirely, you'll have something like this. Let's assume this is how the slice is. And I'm having a tumor here. And that tumor is going to be myometrium. Let's say that we'll put the myometrium in a different color. Fine. Let's assume it's going till this. Okay. This is the slice. Take the entire slice and ink the entire surface from the isthmus till the top. It can also include the cervix as well, doesn't matter. You can cut the entire thing, take out a slice separately. This I want to do it in the first day itself, because the first day itself you can see that, and you keep it, fix it properly, so that most of the endometrial carcinomas will be very, very fragile. It might fall off. Once you fix it, it becomes a little bit firm. Then cut it and embed everything. While embedding, please make sure it will fill into a cassette. If it's not going to fill into a cassette, give more slices. That's more than enough. While you embed, you can say 1, 2, 3, 4, 5, 6, 7, 8, and draw this also on your grossing sheet. And please don't forget to write left and right, right? So draw it completely and gross it completely and give it to them. I am sure that you know how to pick up a left and right part of an uterus. You know the anterior and posterior. I'm sure you know that. The posterior, the reflection of the peritoneum is more deeper than the anterior. With that I can easily say which is left and right. So draw the left and right as well, right? So let's assume now I'm going to give this as a specimen, fine. When I'm going to give this as a specimen, I'll take the third one alone, right? Because here is a lumen, so obviously it will be cut here. Let's take the third one alone. I'm having such a huge tumor, okay, which is going in kind of into my myometrium, and we used green color for the myometrium, right? Let's assume this is the representative section of 3. Okay. Will this fit into one cassette? Will this fit into one cassette? It might not fit into one cassette, right? One more problem for me is sometimes myometrium alone will be extremely thick. Because of the invasion, the myometrium alone will be extremely thick. That also might not fit into one cassette. If the entire thing is not fitting into one cassette, I'm okay to sacrifice this part. But if this part of the invasion alone is thicker, I want you to do something called a sequential crossing, right? So what a sequential crossing means, if this myometrial invasion is too thick for a single cassette, I don't want you to trim this off. That's not the way to do it. You have to do something called a sequential crossing. So what you do is you cut it here again, and this part is already inked, so give this part separately. So I name something as 3A, and I'm going to give the part which is cut here, right? And 3B will be the second inked margin with a little bit of tumor. So this is called sequential crossing. I just cut into two. So once you sequentially cross, here you have to ink, and here you have to ink. This is just to convey the information to some other pathologist when it goes for a review. It's a huge myometrium, so I've done a sequential crossing as 3A and 3B, which means this entire tumor is single. Because once you want to measure the invasion into the myometrium, it might be helpful. If you discard a few of that, my measurement might not be correct. If the measurement is not correct, if it's not, the 50% criteria is not properly done, I might either downstage or upstage the tumor, right? So sequential crossing is required whenever it is very, very thick thick myometrium. Keep that in mind, fine? And this is the procedure to do it, because if it goes for a review somewhere, if it's properly and sequentially crossed in its name, they know that there's a proper job done. Definitely it will not be a problem at all. See, you will know the pathology is good or not by the way they write gross and the way they section. My diagnosis is secondary. If you section everything correctly, the diagnosis automatically will be correct, fine? Okay. So this is how you're going to do. And like Manpreet said, that I will definitely take from the lower uterine segment, the ischemic endometrium should be taken, obviously, the ovaries and representative size from ovaries and tubules. Parametrium, the reason why I didn't comment on parametrium is, in all simple hysterectomies, parametrium will not be there, right? Most of the cancers, endometrial cancer these days, the hysterectomy done is simple hysterectomy. So first and the foremost thing, while grossing, you ought to know the simple or Wertheim's. In which hysterectomy you will see parametrium? Simple hysterectomy or Wertheim's hysterectomy? Simple or Wertheim's, where you will see parametrium? You will see parametrium only in Wertheim's hysterectomy, right? In a simple hysterectomy, you don't see a parametrium, right? So that's very important, because what happens is, many of us, when you say parametrium, tell me honestly, how many of you just go and shave the part of the uterus and give it? That's what we generally give it, right? We know that this is a uterine cavity, we just shave this part and we call it a parametrium. We just shave this part and then we call it a parametrium. That is not parametrium. A simple hysterectomy will not have parametrium. You cannot report on a parametrium in a simple hysterectomy. If you report, you are artificially creating your own parametrium and reporting. Only when it's written Wertheim's hysterectomy or few modifications of hysterectomy, only in those conditions parametrium will be seen. So don't give parametrium for every uterus you get. I'll show you how a parametrium looks. We saw that in a radial trachelectomy specimen. This is how a parametrium looks. This is actually the parametrium, fine? So if this much thickness of parametrium is seen on sides of cervix, in a uterus also it should be this thick. It will be like a wing. So parametrium is that, right? So if you don't see that, which means there's no parametrium. Like in the first case what we saw, I don't have a parametrium here, right? There's no parametrium here. If there's a parametrium, it will look like a wing. Then yes, give from parametrium. If parametrium is not there, for simple hysterectomy parametrium is not there and you're not required to give parametrium, fine? So ignore that. Most of the hysterectomy done these days are simple hysterectomies only, fine? So that's how we gross your genital system. We'll see some more thing in soon, fine? Okay, I want you to, we took one example. The same way, I want you to comment on this and if possible, come to a differential diagnosis, fine? I told you how to comment. First what it is and the cross gut surface, everything. So do comment, then I'll tell you what it is, fine? I'll give you 30 seconds. Think and comment, whatever comes to your mind is fine. Even if it's wrong, it's completely wrong also, it's fine. It's from a 40-year-old person, breast lesion, okay? This is from article. So you do not have the correct diagnosis. I just want you to comment. If you comment and kind of go in the correct direction. That should be more than enough for me. So what do you think is the diagnosis? Can you guys comment? We can start with the specimen, then we can go to the diagnosis. Anyone? I want you to start with the specimen at least. Okay. Is the lesion, just start with, is the lesion a mastectomy or not? That at least. It's not a mastectomy, right? Can I say it's a nodule? It's just a nodule. It's just a breast nodule which is being excised. Maybe a nodule being removed from the breast. Does it look well circumscribed or not? Well defined or not? There are actually two nodules here. This is one, this is one. So the way to go ahead is, there are two nodular lesions from the breast. One smaller measuring so and so and larger measuring so and so. The smaller as well as larger kind of looks well circumscribed. It's not infiltrative. The reason why I can say it's not infiltrative is this is your normal fat. I can see the fat here, right? It's definitely not infiltrative. It's decent. It's decently circumscribed. On the cut surface, it is homogeneous. You want to use the fancy terms, gray tan appearance. No areas of hemorrhage. Nothing is there. I'll come to it. So you have to feel the tissue as well, right? So it could be a fibroadenoma, but to call it fibroadenoma on the gross, I need a very classical finding. Do you see the finding? We look at the first nodule, okay? Does it look like a fibroadenoma? I have just zoomed it inside. To call it fibroadenoma, I need one classical finding. What is that? Do you see them in here? Gross also, you can pick up fibroadenoma very easily. Do I see the finding here? The finding is the compressed slit-like spaces, right? Do I see the slit-like spaces? I don't see them, right? I'll go to the larger lesion as well. I'm not seeing the slit-like spaces. Maybe slight here, but this is not enough for me. It should be a very well-formed slit. Because fibroadenomas, the microscopy will have the compressed ductule by the overgrown stroma, which will give a perfect slit-like appearance. Fibroadenoma grossly will have a slit-like spaces. I don't have the slit-like spaces here. But can I say that it looks like a stromal lesion? Am I right in saying that it looks like a stromal lesion? It does look like a stromal lesion, right? Right? Okay, so it's homogeneous. I would keep it outside a little bit. It looks like a stromal lesion. So that's more than enough for you to comment here. It's two nodules, so and so size, homogeneous appearance. If you can feel it, you can write fleshy or whatever it is, or firm, whatever it is. And most likely a sarcomatous lesion. I wouldn't put the term sarcoma. I'll put the term stromal lesion because I don't know whether microscopy could be benign or malignant. So most likely a stromal lesion, right? See, when you're looking at the gross, unless and until you have the classical appearance, don't call it fibroadenoma or phyllodes because it's a stromal lesion. Both fibroadenoma and phyllodes are stromal lesion. In gross, if you're able to differentiate, it's an epithelial lesion or stromal lesion, more than enough for me. It could be phyllodes, it could be fibroadenoma. I need microscopy for that. Phyllodes not always to be 10 centimeter. That's for undergraduate. Phyllodes can be 2 centimeter also, right? That's more than enough. Like GD said that it's a lump which has been removed, well circumscribed, pushing margin, no infiltration. Most likely a stromal lesion. My DDs could be fibroadenoma, phyllodes. Actually, this is neither fibroadenoma nor phyllodes. This is a case of PASH. I'm sure I must have heard about PASH, Pseudo Angiometer Stromal Hyperplasia. This is a case of PASH, fine. So it's a stromal lesion. My possibilities are this. I would require microscopy to confirm it. If they ask you what is the first diagnosis, again you are going to say that because of the commonality of the lesion, I would prefer fibroadenoma, but I'm not seeing the slit-like spaces. So I definitely I would want microscopy to comment before commenting on a definitive diagnosis. No one expects you to diagnose on gross. You just have to be a bit firm, that's all. There are a few spotters. Spotters you have to pick it up, right? Otherwise, just leave it blind-ended, a stromal lesion with differential diagnosis. This is a spotter. What is this? I hope you are able to appreciate that. Okay, this is an mastectomy specimen which is being serially sliced, and I hope you can tell the diagnosis. Few things are spotters. Spotters you have to pick it up. Can anyone comment on the diagnosis here? It might be a bit difficult, but you can do it. 30 seconds. Look at it, observe, and try to give an answer. Deshmukh carcinoma is correct, but can you be little bit more specific? It's not wrong. Carcinoma is definitely correct. Hina as well as Deshmukh. Can you be more specific? Actually, there is one classical finding. I'm not sure you are able to appreciate that. Okay. Can you describe the cut surface? Apart from the exophytic growth, can you say that how it looks? Is it homogeneous, heterogeneous, hemorrhagic, shiny? How does it look? Because that will help you to come to a diagnosis. As I said, this is a spotter. I should not miss these cases. No? Okay. This is actually a case of a mucinous carcinoma of breast. Though if you're not able to appreciate here, that's fine. But mucinous carcinoma is a spotter. You should not miss that. Fine. Mucinous carcinoma is a spotter. Those shiny spaces and the cystic ones are the nuisance, right? Mucinous is a spotter. Papillary lesions of the breast. If you can see the papilla is a spotter. So for a mucinous carcinoma, I should not comment it's a carcinoma. I should be more confident saying it's a most likely a mucinous carcinoma of breast. Still, I need microscopy to comment whether it's IDC with mucinous change or a mucinous carcinoma of breast. Papillary lesion, again, it's a papillary lesion of breast. There are multiple different types of papillary lesion. I need to confirm with the microscopy what type it is, fine. So these two, at least in the breast, grossly you can come to a fair enough of differential diagnosis, right? So these two you should not miss. Others, if you say it's in carcinoma, benign stromal lesion, that should be more than enough, fine. Few pointers while crossing breast specimens. I am sure that breast mastectomies are the commonest thing which comes to our hospital, right? Very, very common, because the breast cancer being very common, almost every hospital has lots of mastectomy. There are few things still we don't do it correctly. I just want you to do make sure in future you do it correctly. Obviously, the orientation of the breast is important. You know that long lateral and short superior is the general dictum. You go with that as well. Serially cut. And when I say serially cut, the cut should be very, very perfect. It should extend from the tip, the posterior aspect. It should go till your skin. It should be perfectly serial, right? Don't leave little bit till the skin, because that's the general thing that we won't do it completely, right? Let's assume this is skin and I have a breast mass till this. We'll cut this and then we'll leave it little bit lethargic because the knife is not a bit strong. Don't do that. You have to cut from here till here. You should go till the skin. Once you reach the skin, it's fine, because most of the time the tiny lesions which are in the subareolar subskin space are being missed. Don't do that. In a retrospective study in the college which we studied showed that there are quite a few significant number of lesions which are in this location are missed unless and until it has been mentioned pre-operatively. Please cut till the edge, right? Second, margins. See, the margins, I am not sure how your college has taught you, so I would want you to go with whatever the way your college has taught. The lateral shaved, medial shaved, superior shaved, inferior shaved. If you want, go with it. In our hospital, we don't give margins for breast parenchyma if it is more than 2 cm. It's a bit of more confidence. We don't do it, but what margin we require and what margin my consultants want is this. The posterior margin is what they want always, right? So none of the surgeons or the medical oncologists wants the lateral margins and the medial and the superior and inferior margins if it is not close. If it is close, definitely they want, and they also want this centimeter as well. If it is not close, I'm having a lesion in the central quadrant. This is a lesion. It's definitely far away, right? They don't bother about that. What they want is the posterior margin. That irrespective of whether it's close or far away, they do want it. That's the only thing we give. For others, we rate that since lateral or your medial or all the margins is more than 2 cm, grossly, I am not going to give a microscopic section, not required. That's acceptable in most of the hospitals. I would leave it to your own hospital what protocols they are, based on that you give it, fine. But posterior is important always, fine. And the number of lesions should be mentioned. The one advantage of serially grossing is some tiny lesions which have been missed in the clinical examination could be picked up here. If you see the number of lesions, you have to mention first lesion in so and so space, so and so size, second lesion again so and so size. The most important thing is the gap between these two lesions. If it is 0.2 centimeter, it's the same single lesion. If it is 5 centimeter apart, it's two different lesions, it is multicentric, right? So the gap between the two lesions should also be mentioned, because that is important determining factor while assessing the TNM stage, and also telling whether it is a single tumor or a multiple tumor, right? So the gap is very important. If you go to the TNM new edition, they'll exactly specify when to call it multiple, when to call it single, and how to measure as well. And measurement, again, on gross is not the correct way to measure. If I'm having, let's assume I'm having a lesion like this, it's infiltrative like this, with a little bit of fat surrounding them. This is the entire lesion. Let's say that this is 3 centimeter approximately, or 4 centimeter approximately. Grossly, it might look 4 centimeter, but the same thing what we did for endometrium, we're going to do here as well. I'm going to slice it completely, a single slice, and do sequential crossing. Give this in maybe 2A, this in 2B, and ink this part, ink the center part, so that I know that these two are adjacent to each other. This is just for, if it goes for a reference, you'll not be in any problem. You have done it perfectly correct, right? So let's assume that this tumor is 2.5 centimeter, this tumor is 1.5 centimeter. So the entire dimension of the tumor is going to be 4 centimeter, right? So it should be confirmed on a microscopy, though gross is the way we go forward usually, but microscopy is required, because TNM, the scoring, the staging alters the treatment radically. So at least for breast, please do that. It's ideal way to do for every cancer. If it is more than 2 centimeter, don't put in a slide, sequentially gross it and measure the centimeter microscopically, because who knows, there might have been few cancer cells here that will make it more than 5 centimeter. That will make it T3, T4, right? So that's very, very important to measure it sequentially on a microscopy and then give the TNM staging, fine. And the nipple areolar complex, I'm sure you know how to give it. You just give a cross section in the nipple areolar complex. The day before itself, cut it when it's fresh, so it's easier for you to give a section, because nipple areolar complex is undoubtedly required for the staging purpose and to see whether it's a pituitary involvement or not, fine. Okay, just one thing, comment on your diagnosis. We will end with this. This is a very, very simple case. I hope you get it correct. 30 seconds. Sorry. Just a second. Just a second, sorry. Yeah, diagnose. Okay, your diagnosis. It's a very simple and straightforward case. I hope you won't make a mistake here. It's a cut section of a femur. You can see the condyles. Okay, the growth is in the epiphysis, metaphysis, or diaphysis. Start with simple pointers, then we'll lead to the diagnosis. When you have a bone, the first thing is the laterality. Comment on the laterality. Okay. And before asking or discussing about any bone tumor, ask the patient's age. That's more important. To call it an osteosarcoma or everything, or any bone lesion for that matter, I need to know the age. If your examiner has not provided you the age, ask the person to give the age, so that you'll be much more confident in calling it. Don't go with the size of the bone, that this person's age, but I do want an age to comment it. Ask that first, because they will know that okay, this person knows what they're doing. Second is laterality. then the site of the lesion, whether it's an epiphysis, metaphysis, or diaphysis. I would say this is more of an epiphyseal metaphyseal lesion, right? It's more close. This is the epiphyseal growth plate, right? It's more towards epiphyseal lesion, right? A fleshy growth, fine, a maternal-like growth, okay. Then the extension. Here I would say that this is most likely epiphyseal growth, kind of moving towards the metaphyseal junction. Next, the most important thing is the bony cortex. See, this is very, very important. This is what is going to tell you what's happening in this lesion. In this image, the cortex is intact or it is breached. This is your bony cortex. Because it's very, very important to comment on the bony cortex to come to a diagnosis. Because most of you have called it an osteosarcoma. Here the cortex is intact or breached. Can I say in this image cortex is intact? It is intact? Yes. If it is intact, the possibility of osteosarcoma is less, right? So that's the first thing I want you to look for. It's an intact cortex. So this is very, very important if cortex is intact or not. If cortex is breached, then say the soft tissue invasion. So these are very important to comment on. So I would comment this image as a cut section of a longitudinal section of a bone showing a kind of an ill circumscribed lesion. I wouldn't say it infiltrative. It's not well circumscribed. It's not perfectly circumscribed. It's not invading much as well. An ill circumscribed hemorrhagic lesion with bony components. These are bony components, right? That will be the ideal way to describe it. Hemorrhagic, definitely, like Manpreet said, it looks fleshy because of the blood there, right? Hemorrhagic lesion with areas of bone formation. The tumor is destroying the bony lesion because it's destroying the bone, but it's not invading the cortex or not extending into the soft tissue. So I'm thinking of an cystic lesion because if it is so much of hemorrhage, definitely be cystic. If an age is given, let's assume that this patient's age is 35. What could be the cause? 35-year-old, this appearance, what could be the cause? $35-year-old. Okay, this is a classical case of an GCT. Okay, it's a giant cell tumor. It's an invading expansile tumor destroying the bone. It's a classical case of a giant cell tumor, right? Again, it's based on the age, based on the location. My differential diagnosis are this. This is how you're going to end for any bone lesion. The differential diagnosis should always be based on the age of the tumor, and I do want radiographic and also the location of the origin to comment on further thing, right? ABC is a bit unlikely in this situation, fine, because ABC might still be a possibility, could be an easy differential diagnosis, but first 35-year-old, I will put GCT first, then maybe ABC and other cystic lesions of bone. It could be an osteosarcoma also, but keeping in mind 35, it will be way down the order, fine. It will not be a cartilaginous tumor. The fleshy appearance is not cartilage, it's due to hemorrhagic, fine, okay. So while grossing anything in the bone, it should be perfectly, the entire bone, whatever it is, should be sampled. This way of sampling is especially for post-chemo specimens. For a pre-chemo, mostly we don't get amputations these days before chemotherapy. It's always post-chemo, and post-chemo, like we did for your endometrial carcinoma, it should be perfectly, the entire cross-section should be given. And fixation is very, very important. Before starting a bone dissection, that's via the, you will have a bone saw to dissect it. Before going that, the first and the foremost thing is to give the bone marrow. The bone marrow, the medullary cavity should be given first. If it is not given during frozen section, give it. If it is done during frozen section, I need not give it. If it is not given during frozen, give that first, put in decap, take an entire slice. You can easily appreciate the bone, the tumor here, right? Maybe in this part it's necrotic. The reason to give entire tissue is you have to comment on the percentage of necrosis, because that's very, very important. That's what tells you how well the tumor has responded to the chemo or not, right? So that's important. So entire thing should be sampled. The volume of tumor is 100%, and the percentage of necrosis in the 100% volume of tumor is, let's say, 55%. That will tell you, okay, it's a decently responding tumor. I can continue with this chemo or not. Post-surgery will be a very important call. I need to give that, fine. There are chemo responsive scoring system available for every single bone tumor. For Ewing's it's different, for osteosarcoma it's different. Based on the primary diagnosis, you can use the respective scoring system to go and score and to tell the good response or a moderate response or a very poor response to chemotherapy. Fine. Okay, that's how you gross for bone. I think I'll stop it here. We did see about one case, microscopic case here, query synovial sarcoma. I hope it is synovial sarcoma. And we have to look for your, we did see about the uterine lesion, that's your endometrial polyp. We had a look about two breast lesions, one PASH and one mucinous carcinoma of breast, and we did see about one bone lesion as well. Fine. I'll stop it here. For postgraduates, the update is this. This will be my routine. I'll try to maximum stick to my routine. If I'm not able to do it, I'll definitely inform in the Telegram group. So every Wednesday and Saturday will be for PGs, maybe for your second year and third year postgraduates. If a first year wants to learn this, there's no inhibition at all. You can definitely come and watch these. Okay. And for first year, it'll be on Fridays. Okay, especially for first year PGs. If you're a second year, if you want to join the first year class, you are definitely more than welcome. And all of these classes will be in the form of special classes, which will be free of cost. Yes, Dr. Hina, you can watch these classes at any point of time. You can follow my profile under Unacademy app, Ranjith. Pathocorps it will be written. Once you go there, all the special classes will be there. You can watch them at any point of time. You can watch them on the laptop. I would prefer you to watch live, because once you postpone something, we know about us, we'll never look back at it, right? But you can definitely watch it at any point of time. Okay, fine. So I'll end it here. Thank you for your time and hope to learn more with you guys. Okay, thank you. Bye bye.